Hi, my name is Jim McGreevy, and welcome to Second Chances. And I have with us today somebody who's not only an accomplished and published academic, a researcher, providing valuable guidance and direction to the Essex County Corrections Civilian Task Force, but someone who is a trailblazer in terms of public policy, particularly as it applies to individuals suffering from mental health and addiction challenges within the carceral setting. And so with that, the very esteemed Pam Valera, Professor.
Hi, how are you?
My friend. And can I ask you, are you at Rutgers now?
Yes, I'm in the conference room currently.
Good. And what's your I mean, there's so much to ask you. So can you just give me a little bit about how did you come into this place and how did you come to study and relish public health, mental illness in the carceral setting?
Yeah, I mean that's a lot. So
it is a lot.
I come from a family with experience in the correctional setting. And I think one of the most significant experiences I've had was having my father incarcerated in California, in Los Angeles, and spending a lot of my formative years away from home due to substance use and violence. And my uncle was incarcerated, also related to substance use and mental illness. My cousin was incarcerated and assaulted in Los Angeles County Jail. And I've had family members, including my uncle, pass away from incarceration due to overdose upon release to the community. And as a first gen, growing up, everyone that I knew was, involved with the system in many ways, suffering from either mental health challenges or substance use. And so it's not just I study it, I've lived through it, and I still have family members who encounter it on a daily basis. So for me, it's not just a curiosity about why do I do this? It's really more about how do I change the system as we know it and help promote better wellness and opportunities for people that are inside the system and also returning from home.
So, I mean, obviously that personal experience of grappling with addiction and prison, can you give me your first sense of your impression of prisons?
I mean,
and your first impression, not your impression now, but the first impression you had as young Pam, what was your sense of what prisons are?
I mean, I didn't know anything about it until I was exposed to it. I thought that it was a horrible place, my father was away for a long time, and really my mom didn't really say that he went to prison. He just went away. So when we found out and we came to really acknowledge that, it was a really
And she was concerned that if she said to you how you would react to that and react to him, I guess.
Yeah. I mean, it's being incarcerated is, I think there's a lot of stigma involved in having family members who are incarcerated and then involved in the system. And I don't think that's changed today. I think one thing that I learned while my father was incarcerated is that there were opportunities for him to gain gainful employment in the community. It's sad that he had to learn things like, what construction work was like, or, even getting an education inside the system, because there was no way to get that in the community. And that was a benefit of, through the Gains program. That was a real benefit for our family because we grew up very poor, and having that experience. So there's a plus and minuses about incarceration. I think my father never talked about what happened inside the facility, whether he was harmed, whether he was bullied inside the facility. I don't really know. I just know that when he came home, I was fairly young when he came home, that he was a changed person, very quiet.
How so, Pam?
He was just, still now, emotionally distant, physically distant. He stopped drinking. So that was a benefit of incarceration. He stopped being abusive. That was another benefit. I think that helped a lot. That was, on the flip side, my uncle died, did never recover from his incarceration, and also my cousin as well. And I think the difference there is that they didn't have the network, coming home. I mean, my uncle was homeless. He came home with nothing. But basically, my aunt was separated from him, divorced him. She had 2 young children, and really left him, and he didn't have a place to go. So there was lack of reentry services that he was aware of, and so he succumbed to substances, and with his mental illness, and same with my cousin. I mean, my cousin also didn't have that system in place. My mom decided to take my father back, for better or worse. And so I think that system helped. But yeah, so and then, as I learned more about it, and friends went in and out of the system, that was just something that all of us knew about. It was part of our journey, I guess. The young girls went into gangs, experienced that because they needed a place to belong. And the young men, basically went in and out of the system. And that's what I knew, and I'm surprised that I was able to get out of that and leave that behind. But it's still part of me, and I still am impacted by that. And that's, I've been doing this work, both, having lived experience in it, but also, working in this field for a really long time. And I just, for me, it's more about how do I provide opportunities for people coming home, and how do I save lives? I always go back to, like, if I was the adult now and my uncle would be, my uncle was returning from home, perhaps he would still be alive today, and perhaps my cousin would not have been sexually assaulted in the Los Angeles County Jail for being a gang member. And so, those are things that I look back and say, I wish I had the resources that I have now to be able to help them, but that's neither here or there.
And so what's the purpose of prison?
I mean, the purpose of prison is to house people. I mean, they do something bad, they commit a crime, and they're inside of the system. Now, again, I don't want to generalize all prisons, because not all prisons are the same. There are some that are there are some states that are trying to do their best. There are some that are horrible that you don't want to go into. And so ideally, what the purpose of correctional settings should be is to rehabilitate. And long time ago, before we had the high rates of incarceration as we know it today, that is what it was for. It was to, provide people with opportunities so that when they return from the community, that they would be able to live, get the second chance, or live better lives. And then since the boom of incarceration, we had more brown and Black people in the system itself, it's changed to more of a punitive, more security, more of a warehouse for people that are inside. That's very unfortunate, because for people that don't have the opportunities, it would be one way to have that training, education, college prep, all of those things. And some places do provide that, right? I mean, we know that that is being provided. But it's unfortunate that has to happen in the correctional system. It should be happening in the community, but sometimes it's not. So ideally, it would be to rehabilitate, to provide gainful employment, but realistically, that's not happening across the board.
So why is it that Americans keep doing the same thing over and over and over again? And to your point, when you say it's not happening, so why does it keep happening? Why does prison, as we know it, keep happening, despite the fact that we have these, to say the least, less than satisfactory results?
I think it's poor leadership. I think we don't have enough people.
Is that a little tough? I mean, when you say poor leadership, whose leadership? You're talking about corrections, the Bureau of Prisons,
I think
political?
policymakers are really not attuned to what the conditions are inside the facility. If there were more people with lived experience who are basically politicians or working in government who have that experience, I think we would have a different system. Because I think having lived experience changes the way you think about how to solve a problem. Having people that's part of the system also is really important too, and that they can think about what creative ways to address these issues. If we look at if we look at history, things haven't changed. We have really good intentions as a nation, but when it comes to implementation, it hasn't changed at all. We still go back to our status quo. And I think the key is like, if you have diversity in leadership, where you have people with lived experience really being part of the table and being the decision makers, I think that'll go a long way. And we don't have enough of that, actually.
Do you think that would provide the needed change necessary?
I think that would provide the voice, and I think it all comes down to money as well. There is a lot to be said about the institution itself. I mean, a lot of people who are incarcerated work really long hours to support society. They make 25, 50 cents an hour, sometimes even sometimes $1 or less. And so they are the engines of our community. And so when we think about who's making these changes, what kind of policy changes are happening, how many of those individuals have the lived experience to say, I think we need to find better solutions. And if we really invest in people, we don't do enough of that. It's a personal investment. We invest in people and really take the time to help them be successful, we would be in a different situation. And investment means financial investment, emotional investment, all of those things. And I always say, and I've been saying this for a while, I think every academic institution should adopt a jail or a prison and really invest in that. So invest in providing the mechanism, that support that is necessary to make sure that every single person housed in that jail will come home, will have the opportunities that they need. And that is, if someone is suffering from mental health and they're getting treatment inside the facility, there's linkage to care. There's immediate linkage to care. But I think that's a big ask, right? To say, let's invest on people. We do a really good job investing in corporations. And I mean, but
there's a rate of return. I mean, we're not investing in corporations because we're good guys. People invest in corporations because they make more money.
Yep.
So, I mean, that's a capitalistic financial incentive.
Definitely.
The question that I have is for you is, when you talk about linkage to services, one of the primary reasons I think people fail is that services aren't coordinated. That whether you're talking about an ID, you're talking about, legal support, access to Medicaid, access to SNAP, general assistance, access to job training, that all of these services are before you. And I know we work hard to synthesize them at NJRC, but if you didn't have NJRC and you're in Milwaukee or you're in Los Angeles or you're in Nevada or you're in upstate New York, what do? I think it becomes overwhelming, and it just, people just get a case of the efforts and walk away. Is that fair? I
mean, I think that another issue is the wraparound services. We have very limited of that. I mean, you have NJRC that does its best to provide those wraparound services, that linkage to care, but you're not in every county, to really do that well, right? And I think the current services right now are limited in that capacity. I think even so, I had sent, I guess, someone with a link of resources to a county, and one thing, what we had to do is call every single agency to ensure that they are still one active and that they work and that they provide services to the people who are coming home from correctional facilities. And I can tell you that even those people that we've called didn't even know that whether they provide services or not. And so I think there has to be an overhaul of what those services are, and perhaps more support to address that. And I think what wraparound services are a really good way to do that. We did that really well with HIV. You know, when HIV was an epidemic, we did such a great job. We had programs in the correctional facilities where we educated people in HIV. We talked about prevention and provided interventions inside the system. And the moment they were coming home from correctional facilities, there was an immediate warm handoff. Someone was right there to provide, to link people into care and to actually take people to where they want to go. And we don't have that for all the other chronic diseases. We don't have that for other physical health issues. And there's such a need for mental health, that warm handoff. But we don't have that because, it's just something that I think we all grapple with. It's not an emergency. It's a crisis, but it's not an emergency.
Well, you talk about we've got it for HIV. We've made strides on addiction. Wouldn't you agree?
Yeah, it is. Yes, because
so why can we tackle it for HIV for addiction, but not make those changes for mental health?
Because HIV and opioid use addiction or disorder are considered public health emergencies. So there's federal funding right now set aside for these two important national problems that we have. And until someone in the president's, I guess the president would have to do it, to say mental health is a public health emergency, similar to what we did with COVID, then there will be efforts to address that, and that warm handoff will actually happen. We were so successful with COVID, right? There were a lot of things in place to address a public health pandemic. Money put aside, and if we can do that for mental health, I think it's a game changer, and it's definitely a game changer if we can do that for mental health.
But why can't we? I make up that it's, and I don't mean this disrespectfully, that lawyers and judges have no problems, but not no problems. Let me be careful with my language. Lawyers and judges understand the legitimacy of putting people in prison for violent behavior. But lawyers and judges are not medical professionals and are loath to make the decision to deprive someone of their civil liberties because of their mental health status and place somebody in a mental health step down, such that it's more natural for a lawyer who's not a healthcare professional to send someone to prison than it is to deprive someone of their constitutional rights for the purposes of receiving mental health treatment. That's a difficult decision to make, particularly when there's not sufficient clinical evidence. Does that make sense?
It makes sense, yeah.
So what do you do with that?
I think the biggest issues that we have is we lack the appropriate guidance in the forensic psychiatry field to really understand and grapple with the issue. So
say more.
I think one thing that we need to do is to advocate for more correctional psychiatrists to educate the lawyers about the conditions that are impacting.
Pam, I will tell you, like at NJRC, it is so difficult to employ psychiatrists for any number of reasons. One, the level of Medicaid reimbursement. Two, the insurance exposure. What do you do? So like you have an agency that wants to provide, like on the OBGYN side, I have Gloria Bachman. Yesterday we had this great conversation, 60 OBGYN residents, tremendous. after a long, dearth of responsible healthcare for women, that we have a great partnership with Commissioner Kuhn, et cetera. Addiction, Rob Carter, COO, great partnerships with Newbridge, with Rutgers, whatever. But on psychiatry, and we've got great partnerships with Rutgers Medical School. Dr. Petros Lavonis, president of the American Psychiatric Association, a leading voice. But why is it so difficult or so expensive for a physician to cover the cost of the insurance liability cost or potential cost, that it just becomes a Herculean effort?
Yeah, I mean, I'm not a psychiatrist. I mean, I would defer to Dr. Lavonis, who's the president of the American Psychiatric Association, to respond to that question. I think I think Dr. Lavonis could be an amazing vehicle, honestly, to really advocate for those.
Oh, he does every day. Like,
yeah,
I've got a votive candidate. I'm the biggest Dr. Lavonis, but it's tough though, because there are many psychiatrists that want to be in this space.
Yeah.
And it's either they're in a prison setting, for which many of them would prefer not to be, as opposed to a clinical step down setting. And it doesn't seem to be either or. Either you're in the prison setting,
Yep.
or you're in the hospital, the acute care setting, the Rosa unit, where somebody's going through a psychotic episode. And there doesn't seem like, that space in between that exists on addiction, the space in between that exists on so many areas, doesn't seem to exist for psychiatrists to want to access our population. Does that make sense?
I think one of the things that we're doing with support of the New Jersey Medical School is that we're working on creating a correctional health elective. And so what our students will be doing is that they will be rotating at one of the county jails. That includes folks that are interested in psychiatry to sort of be exposed to that. I think one thing I've noticed, especially in academia, is that everyone works in silos, right? And so people don't hear about corrections until on TV, and they think that it's just a horrible place to be. And I think the other thing too is that it isn't until, like, I take a lot of my students to the county jails, to the prisons, and then they're exposed to that, and then they want to actually participate and learn about people that are in these conditions. We in my school, we don't do enough to educate our students about people with incarcerated backgrounds. We look at vulnerable populations, but the vulnerable populations are your people with poor health conditions, et cetera. But there has to be more education from our side to inform our students about justice involved populations. What do they look like? What are they experiencing? And providing opportunities for students to be exposed to some of these health inequities inside the system. And I do that a lot. And so my students are now interested in correctional medicine. My students are working towards, working in reentry. Those are the kind of things that that I'm exposing my students. The more exposure, the better.
So what happens so you're exposing your students to mental illness, but say, for example, for the person who's in prison, whom he or her himself may not be exposed to the mentally ill. What about the conflation in prison between two different populations? The mentally ill, and then there are those that are there, as well as those that are engaging in violent behavior. What happens when these populations mix in general population in a county jail like Essex? And you've spent a lot of time. Could you just share a little bit what you've done in Essex County Jail?
Yeah. I mean,
and the report and maybe we can back up and talk a little bit about the report you did with our dear friend, Dr. Chris Pernell, and the medical outcomes, but focusing, if you can, on the mental health aspect.
Yeah, so Dr. Pernell and I developed a comprehensive report looking at the social determinants of health inside Essex County Correctional Facility. And we looked at every unit's including mental health. And one of the things that that we noted was that the lack of or limited mental health services that are being provided to the general population. So, I mean, majority of the people are experiencing stress and anxiety, but the clinical staff really deal with people with severe mental disorders, and therefore, when someone from the general population is having, you know, some sort of a panic attack or anxiety attack, it's challenging to sort of figure out like who the hierarchy of mental health need, right? And I think once you mix those populations, from someone who's experiencing, you know, someone who necessarily doesn't have a mental disorder but is coming in with anxiety and stress because this is their first incarceration experience, and someone with someone who with a major depressive disorder or a personality disorder, I think it impacts all of the populations, even those that don't have, you know, a severe mental illness. I think eventually, because of the nature of the environment, they end up having, I mean, you know, there's been studies that show this, right? People that are experiencing very limited mental illness and end up, because of the exposure and the stress that accumulates and the violence that happens inside the system, ends up having a mental health challenge upon reentry, upon release. So, but I think the major issue in that Dr. Pernell and I talked about was that there's just a lack of mental health professional staff that are inside the system to really care for 2,000 people. You know, you would need to, you know, quadruple the mental health staff to really deal with everyone that's impacting distress. And that's also helping the correctional police officers do their job well, because they're also experiencing distress inside that community. It's a stressful environment being institutionalized. And so, you know, we have to do better in, again, in humanizing the problem, but also investing. I go back to the investing of people. I understand the rate of return, sure, but the rate of return for a person is insurmountable. You know, they will not only impact their family, but the community that they go back to. And so that personal investment that we have is and that we just have to shift the conversation, honestly.
We have to what?
Shift the conversation to look at investment in us, in the people that live in live in these situations.
Well, what about when the two very different populations collide, between those that are mentally ill and those that are violent, and they collide in this fight in a pod and a fight in a hallway? What's the right answer? And just parenthetically, I know this from Essex County, or you know, the chief of staff philologist says, well, at X year the percentage of people that were mentally ill was Y, but now it's so much greater, it's Y times 2, Y times 3. And so now you just can't have two pods for the mentally ill, when arguably it's almost becoming, you know, 45-55, 48-52. And does this result in violent interactions between these two populations?
Absolutely. I mean,
could you just share with us what's happening around the country in county jails?
So let me just give you like some prevalence rates. So, you know, when we look at the mental illness or mental health challenges in local jails, about, you know, close to half of the people that are incarcerated there are experiencing mental health problems, right? These are
close to half.
Yeah, close to half. So these are people that have already been diagnosed with either major depressive disorder, bipolar personality, PTSD. But I think that's underreported. I think that's undercounting the folks that haven't been diagnosed, because, you know, with assessment, they ask you a list of questions, and if you say no, of course you don't have a mental health challenge and so forth. I think it's probably close to maybe 60% of people in local jails have some sort of mental health challenge. And so when you mix these people together, you know, people that are there for violent situations and people that are very vulnerable, due to a mental health challenge, I mean, you're gonna experience a lot of, just chaos, across the board. And so we know that, correctional police officers are suffering from distress because you have people who suffer from mental health challenges or disorders throwing feces at them, causing, throwing urine at them. Some of them are some of them are refusing to eat. Some of them are, then you have some of those that are experiencing personality disorders, trying to manipulate the situation. It's a major, serious problem that a lot of people don't quite understand. So, I mean, if you want to look at as a whole between state prison and jails, we have about like 64% of the people in there in both of these systems suffering from mental health issue.
So they're suffering from mental health issue, but what happens when they collide? I mean, you sort of alluded to it directly, but indirectly, but it becomes typically a very violent.
It's a very violent, destructive environment. When you mix people with different types of.
So how do we keep them apart? How do we keep it that if Jim McGreevy comes in at 2:00 in the morning on a 2:00 on a Saturday morning, and I have a history of mental illness or I don't, how do we make it probable that I am not going to be mixing in general population with a mental illness? Or if I don't have a mental illness, how are we going to know that such that I am in general population?
I don't think anyone with mental health challenge with a mental illness should be incarcerated. They should be in a different facility. So my cousin.
So what does that look like, and how do they get there?
I mean, it looks okay. So here's an example, and it's a personal example. We lost my uncle from lung cancer, and my cousin has mental illness, and so he suffered. He ran away from home, and he was on heavy psychotropic medication. The police picked him up, and instead of taking him to the ER to be evaluated, they took him to county jail, and that's where things started to go wrong. So as a 20-year-old kid at the LA County Jail, he was physically and sexually assaulted by the folks that you just talked about, like the people that are experiencing violent behavior and all of those things. He should not have been sent to the county jail. He should have been sent somewhere else. We don't have that somewhere else right now. We don't have,
But I'm saying, if Pam wanted to, where would that someplace else be?
That place would be an assessment. It would be an assessment facility where, if they're coming in at 2:00, it was 2:00 in the morning. It was like 1:00 in the morning. We should have an agency that can, a shelter or some kind of agency that can hold people at least for the next morning so they can be evaluated by a psychiatrist. And that psychiatrist can determine, the direction.
But a psychiatrist, then what is a psychiatrist going to do, Pam? So at the end of the day, all right, Jim McGreevy comes in at 2:00 in the morning in the wee hours of Sunday morning. I get interviewed as a psychiatrist. Psychiatrist says clear evidence of X, Y, and Z. Then where do I go?
Okay, then you go to a hospital.
But a hospital is like a hospital's a hospital. Hospital doesn't want to be in the business of. I mean, hospital. To be fair to the hospital. I mean, I can say that to go to the hospital, but a hospital is going to say, "Whoa, we're a hospital. This is someone who's engaging in a violent act. I've got a waiting room full of families, of children. I can't handle this."
No, if someone with mental illness is picked up because he's suffering from mental illness, he should not end up in a county jail or a
I
county.
agree with that 1,000%.
Now,
That
with
being
someone who is
said,
experiencing violence, of course, I mean,
but putting them in a hospital doesn't have a secure I'm just, I'm being difficult because I'm saying is respectfully, and you're the professor here, but I don't think there is a place to put them.
no, there isn't, and that's why I'm saying there's not a place right now. I'm perhaps there should be a unit in an area hospital where they take on, these patients. Perhaps we need to, invest on, sort of a holding unit. I don't that where we can assess them if they're coming in at 2:00 in the morning the following morning. There isn't a place. We don't have a place.
There isn't a place, right?
What we have is a
now,
jail.
does this go back does this go back to when we deinstitutionalized all the psychiatric hospitals, began in the 50s and the 60s and the 70s, and we closed all the psychiatric hospitals for all the right reasons, but said we were going to create these community-based programs that never occurred. And so now we have mental illness everywhere.
Yeah, it does. It goes back to that. I mean, the idea of the institutionalization of the mental health hospitals was to invest in these community mental health centers, and that didn't come into fruition, and so now where do we put these individuals suffering from mental illness? We send them in jails, in county jails. So the county jails have become the de facto, mental health hospital, the de facto opioid use, addiction facilities. So, they're the people who need, chronic disease checkups. They've become everything that the community mental health center should have been. And so again, where do we go? I go back to how do we shift the conversation where we can start to say, what does it look like to invest in Brown and Black people who are predominantly, highly impacted by our system? What does it look like in the state of New Jersey to do that? And I say that because I've lived through this, and it's not getting any better. It's getting worse. People are now literally dying from opioid use, from overdose. They're unhoused. There's so much going on in our society that we have to have a different conversation, and that's the only way I think things are going to change. At least having a conversation where people with lived experience can say, you know what, this is the way we need to do things. And they need to be in political power. And, and that has to happen because they're the ones who know what it's like to be incarcerated, to experience mental health challenges. And that investment, I think, needs to happen now. I call this an emergency. I really do. And I've been saying
it is an emergency
for years now. It is.
So when you say it's an emergency, what does that mean?
That means all hands on deck. That means what do we need to do to help to save lives before they inside the system, when they come home.
So Pam Valera says it's an emergency. Why?
Because people are literally dying inside the system and and when they're released. And that you have some folks that are in the system who come in with no mental health challenges and then leave with severe PTSD. You have women inside the system who have been sexually assaulted, who've been preyed upon inside the system. You have people that are aging. You have an older adult population inside the system. They've been in there since they were 17 years old, right? And now they're 60. They're going to come home one day. Who's going to take care of them? Their families have already passed away. You have people experiencing accelerated aging inside the system. You have young children who are in the system. Now you have, you get in trouble in the school to prison pipeline. What are we really investing on? It's us. We have to learn. We have to change the system. People are, I see it every day. I've had to use Narcan, you know, I have a bunch of Narcan in my purse and I've had to use it, you know, several times in the last year. People have died because of overdose. I know people who have been sexually assaulted inside the system. You know, we got to invest on each other. We really do. And I believe in, you know, we've become, you know, we've always been very capitalistic, very punitive and so forth. And I don't think you know, we have all these new policies, right? The Criminal Justice Reform Act that sort of helped, you know, reduce, you know, that was the bail reform pretty much. We had the COVID public health emergency. We have the Isolate Confinement Restriction Act. I think we need to do something more than that. I think the next act would be mental health, you know, reduce, you know, I think that should be where the legislation needs to really focus on, is creating either, you know, step downs all over the county jails, rehabilitation. It just has to be something there in policy where people can, you know, really address some of these issues. We're doing a good job with, you know, bail reform. You know, we have less people inside the system now, but it doesn't change the fact that there's still limited services for people that are in need for mental health services.
So when you look at what's happening in prison and on the street, just for a second, these suicide rates, particularly among young persons, is that at all connected in terms of diseases of despair between incarceration, addiction, and mental illness? Or is suicide something separate and distinct? Largely.
That's a really good question. I mean, there are reasons why people die by suicide. And could it be the system? I don't know whether the system itself is creating that type of response. What I do know about mental health and what leads to suicide is that feeling of despair, the feeling of aloneness, the feeling of, I don't have any other choice, I'm better off dead. And that really happens when young people do not feel a sense of belonging, do not feel a sense of, and lack a sense of connection with people. And the prison system, for what it's worth, you know, I think COVID has a lot to do with this, but they've, you know, people are spending more time in isolation, you know, and whether you're in that type of setting, it's just, we lack the opportunity for connection, and we sort of have used social media to do that, but it's not really connection, right? It's voided of connection.
It's what? Voided.
Void, yeah, it voids connection. And I think because of COVID and the pandemic and the lockdowns that people are experiencing inside the system, there's been very little of connection, you know, especially for young people that are inside the system. And so how do you promote connection and so forth? And I think, you know, those bonds inside the system needs to happen. And that's very challenging to do when people can't really connect with each other because of things like COVID and so forth.
Can you speak a little bit about trauma and the role of trauma in mental health?
Most women who enter the facility have experienced trauma. I would say that's for men as well. And I think trauma plays a role in how people react to rules and when they're inside the facility. So when someone's having a negative response towards a correctional officer, they could be experiencing trigger. You know, they could be they're being triggered by how they're being talked to. But unfortunately, the whole aspect of trauma isn't something that our correctional officers really know about. So they think, oh, they're not following the rules. They're having, it's a disciplinary action. And actually it's not. Something's happening inside of them that they're feeling that they need to react this way. And I think that one way to reduce that is to really help the officers identify those mental health challenges, those signs and symptoms of what that looks like, and training them in that would be really useful. But I would say everyone in there has experienced trauma, especially if you're cycling in and out of the system. Getting incarcerated is traumatic on its own. And then having to, manage that on a daily basis, years on, years end, something's you're already traumatized as it is. And so when you're released from that, let's say you spent 10 years in the system and you're released without support, then you have this bottled up traumatic experience that you can't disclose. It's like, let's say you were, assaulted, and those are the kind of things that people don't talk about,
Are we more, do we have greater amount of mental illness today than we did a quarter century ago? Or is it just that we understand it better? Or are we?
I mean, I think we have better assessment and tools now to really understand more of the nuances of mental health challenges. I think we've always had that issue, mental health challenges, in our history, but I think we have greater tools, assessments, more opportunities to really understand it better.
So if you're looking to the future, and Professor Valera of Rutgers says, when Jim gets arrested, and we know that I'm mentally ill, I'm not sent to a state prison. Instead, I'm sent down to a clinically driven program where my illness is addressed. Where are those facilities? In the Valera world?
That's a great question. They're near in an ideal world, they would be local. State prisons are very far away. They're 2-3 hours away from your family, even longer than that. I've been to facilities where like 6 hours away, and the only thing around you is like a forest.
Or a farm.
Or a farm, yes. So no, they would be local. You're immediately taken there. You're provided a bed, you're provided food, because sometimes the reason why we're reacting is because we're hungry. The moment you get arrested and you have a mental health challenge, you go to this facility where we feed you, and there is a social worker there. After you've been fed, you take a shower, and then that's where we start a conversation about what's happening. And then ideally we have your electronic health records, so we can, on the side, pull up your health records that's connected to another agency or area hospital, and then we could see what your diagnosis is, what medications you're taking, and then we can do the proper screening, the proper assessment, the proper diagnosis to find out, do you need to find out whether you need a new medication, and then you stay there for 2 weeks until we connect you. We link you to care. We link you to services upon your release to that facility.
So that's recently there was a young soldier in Morris County Jail Correctional Center with whom we have a great relationship with the warden and the sheriff. My sister Sharon found out through a veterans network that he was there. He was in special housing unit, solitary, because he refused to take his medication. He had been in there, Pam, for an extended period of time. We talked to the prosecutor, we talked to the assistant prosecutor, we talked to the assistant public defender and the judge, a very enlightened judge. Thanks to Hackensack Meridian and Carrier Clinic, they transferred him from Morris County to Carrier Clinic. Intensive therapy, access to psychiatrists, underwritten candidly by Carrier. Psychiatrist there said, well, instead of taking X, pharmacologically take Z, take Z. He had a better reaction to it. He was willing to take his medication. And then after spending time at Carrier, he was transferred to Federal Veterans Housing, where he's doing remarkably well. So, and then the inverse is the person who comes into jail on a Friday or Saturday night, and you know this from helping us at the Essex County Correctional Civilian Task Force, where the person is coming in, correction officer is following the protocol, person has a history of mental health. We don't have a health information exchange. There's no way for the correctional officer to know the person's longitudinally his mental health record. He's put in confinement, eventually goes into general population, engages in conflict with disastrous results.
Yeah.
Go ahead.
No, yeah.
I mean, so the frustration to me is, it's almost as if we can figure it out when the person's in prison, stable, even if it's in a lousy situation, if we're really committed to change.
Mm-hmm.
But the problem becomes when the person first goes in, and I mean this respectfully, because I think Essex is working really hard to do this. We don't have the tools to figure out at that moment, at the moment of entrance, what in God's name we should do with this person. How do we determine that? And where do they go?
Yeah, I mean, I agree.
Is that fair?
That is very fair. I think we don't have an appropriate electronic health exchange where immediately upon entry, their information is on the screen and you know exactly their healthcare issue. We don't have that. I think I would say that Camden County Jail does have that. They have an agreement with their area hospital and their partner organizations where that electronic health care exchange is happening on that side. So they can immediately pull up that patient and say, okay, well, it looks like you're taking this medication. Are you still taking that? Oh no, I forgot a refill. Okay, let's manage that. Why can't we do that at Essex or Hudson or
well, it's a different, I mean, hospitals, it's
sure,
a different,
I get
but I mean,
it.
I think, the county executive, whether it's Craig Guy in Hudson or Jody Francenzo, they want to do it. Yeah. But I mean, the problem is we have to do it on a statewide level. And that's why respectfully, we offered testimony before the opioid, before the commission to say this infusion of dollars that are coming into the state of New Jersey by virtue of the opioid settlement, there's perhaps nothing more basic or appropriate or proper than to utilize these monies for a health information exchange to know the history of someone's psychiatric history, mental health history, addiction treatment history. So instead of somebody walking in with a list of 5 scripts and then adding 3 more, that we have the same way that you can track my cardiovascular history or someone's medical history, you could track someone's behavioral history. I mean, that's, I think was, and to recognize Commissioner Sarah Edelman, she was open to that, but that's ultimately how we spend those dollars. So you've been great, and it's already taken time. So I want to go back to something you said. I wrote, I don't know. Are we in an emergency?
Yes.
And Professor,
I would say we would. I would, we are in a federal emergency, but since we're, I would say we're in a state of emergency. I would say, yes, here in New Jersey, we're in a state of emergency. I think dollars should be invested in.
And why are we in a state of emergency, Pam?
Well, because we have high rates of opioid use, overdose. We still have that as a problem. We have an issue with unhoused individuals. That's increasing in numbers. Unhoused, so homeless individuals, increasing in numbers that are suffering from a dual diagnosis, whether that's mental health and substance use, right? We have high rates of suicide, not just with your general population, but you have high rates of suicide with police officers. You have high rates of suicide with correctional police officers, and we have a migrant situation, that's here. And so, yes, we are. And we need to start thinking about how to invest in people, looking at it from a humanistic point of view, and create these new policies where we say, in New Jersey, we're going to, our first priority is to tackle mental health. And this is what it's going to look like. We're going to look at examining what policies can be enacted in order to ensure that people that are coming home from a prison are linked to care, and linked to care could be defined in many ways. We're going to look at information exchange, the use of technology. People should have the opportunity to use telehealth, to use telemedicine when they don't have access to a mental health professional. We're going to look at public health approaches. We're going to look at addressing the homeless and mental health crisis. There's a lot of things we can do if our state invests in us.
So you would say we are in a state, what would your exact language? Yes,
we are in a state of mental health emergency in the state of New Jersey. I would say that. And I say that because I've traveled all over New Jersey County jails and also the state prisons, and we have to do more to ensure the safety of everyone that's in those facilities. People that work there, people that live there, are housed there. And we need to ensure that when they come home, that they don't die from overdose.
I'm a little overwhelmed.
I'm sorry.
No, it was great. I mean, I've got pages of notes that I've written down. So, I mean, it's powerful, right? So, I mean, when I think about everything of what you said is, we've got overdose, mental health, incarceration, treatment, co-occurring disorders, flashpoints of crisis, and then we have the criminal justice system that may be doing it the best they can, but isn't getting it done. And while we may have figured it out for addiction, we clearly haven't figured it out for mental illness.
May I add one thing too that's going to exacerbate this issue around mental health is climate change. Because
all right, I like it. I don't know if I can take another. I think
I've studied this before, and that when we are,
I agree with you. I mean, yeah.
One of the key issues that I've seen over time is that when there's a hurricane and the state is in public health emergency, the last people to be considered are people that are incarcerated, right?
They're like, bam, I see that every day of my life.
Yes.
I saw that in flooding. I saw that in
exactly.
And
so
well,
if we can address mental health, I guarantee you that when climate change hits our way, we have the tools to help the people and save lives.
Well, I just want to say we're going to have you back. because I think we just focused, and this is good. I think we largely focused on the state of the mental health emergency. I think I could have done a better job at focusing upon some of the solutions. But I think this was important to talk about high rates of overdose. I think it was important to talk about substance abuse, mental health. I think it was important to sort of discuss, understand trauma, understand of where we're at. But at some point in time, I'd really like to have Professor Pam Valera back to talk about what works, what we should be doing in the future, what's Pam Valera's vision of possibility for the state of New Jersey in terms of mental health arena, and how do we grapple with some of these issues. Last thing I'd love you to hear, you've been a great resource for the Essex County Task Force. And I think Essex County is really trying to move in the right direction. What's your sense of, are we moving in the right direction?
I think so. I think we are at the Essex County Correctional Facility. The director is very committed to ensuring that they become a centers of excellence, which I'm really proud of. He took into consideration the step down unit that we had requested, and really trying to evaluate that as we go along. We had trained his officers in mental health first aid for correctional professionals. I'm doing mental health checks in a few weeks with them. So yes, I think there's an investment, and now there's a relationship between New Jersey Medical School and Essex County, where medical students are going to be rotating inside the facility so they can get that exposure. So I think I'm very happy.
And that changes the dynamic behind the wall.
It changes the culture, and the one thing about Director Charles that he's very invested in shifting the conversation, shifting the culture, and investing in everyone that's involved in the system. And I really appreciate that he had opened his door.
And I just want the advocates to understand that, while we're polite, I think we ask hard, rigorous, exacting questions. Nobody perhaps is as many or as pointed as our beloved friend Chris Pernell, but I mean it's Chris is like, I just hope Almighty God is more merciful than Chris Pernell is, or else I'm in trouble. But I just want to say thank you to you, Pam. I walk away from this conversation with a little bit of a heavy heart. Because I understand the scope of the challenges before us. But I'm honored and blessed to have someone who is as aware, as knowing, and as intentional as you are professionally and personally, particularly born of your own personal experience, to grapple with what I would consider to be the toughest public policy issue confronting our nation and our state. So with that, for Second Chances with Jim McGreevy, I just want to say thank you to the great Professor Pam Valera, who we're blessed in the state of New Jersey to have a nation's leading expert on mental health, correctional health care. And Pam, thank you so much for being with us. Thank you.
Thank you so much for having me here today.